All right, welcome everyone. My name is Brett Klein. I'm with Eisenhower Health in our education series here with Desert Orthopedic. And I'm excited tonight to have our colleague Dustin Briggs, who will be talking about returning to sports after hip and knee replacement. And as a few side notes, so please use those who are on Zoom. We have in-person and Zoom. Please use the chat feature initially to ask your questions, and then we will try to get those answered at the end. We will take live questions at the end, and as time permits, we'll also let you unmute via Zoom to ask a question, but bear with us while we wait and hold all those till the end. And then we are asking everyone to please turn off your mic and your video so that there's no interruptions. This will be recorded, as you know, and it will be then posted and edited on our YouTube channel. It will also be on Desert Orthopedic website. And then if you registered via online and all that, I will send it to you within 2 weeks so that you have it to reference. And with that, I'm going to turn it over to Dr. Briggs and get him moving.
All right. Sir. Thank you, guys. Thanks for joining. All right. So I may have maybe should have said return to activity after joint replacement. I'm not sure. The buzzword sports may have scared some people off, but we're not returning to football. Okay. So what are the limitations of returning to activity after joint replacements? That we'll talk a lot about. And there's a lot of factors that contribute to when you can return to activities. Obviously, the incision has to heal. That's very important for swimming and hot tub and all that kind of stuff. The joint capsule has to heal. So for hip and knee replacements, we access the joint through the really thick joint capsule, and that provides inherent stability for the joint replacement. It takes about 6 weeks for that to heal really well. That's one limitation to returning to aggressive sports. The soft tissue recovery, so aside from just the joint capsule, muscles are involved. The quadriceps tendon is involved in the knee replacement. There's a few muscles like the piriformis muscle, which is a small muscle in the back of the hip that gets released. So all those need to really heal before we can be too aggressive. Most importantly, it's the implant stability. And we used to, welcome. We used to use cement to fix joint replacements in both the hip and the knee. A couple decades ago, we started using press fit components in the hip, which means we don't use any cement. We just impact them firmly into the bone, and then the bone actually grows into the metal. And we'll talk more about that as this talk continues. Lately, within the past 10 years, probably 5 years especially, we've started to use press fit knee replacements also with no cement. And so that has really changed how we consider returning to activities. And then the long-term durability of the implants, the wear characteristics of the plastic liner that we use in the knee and the hip replacement, the fixation to the bone, all that stuff determines the long-term outcome, so 10, 15, 20 years. And then for hip specifically, does the approach matter? I get a lot of questions about, is it a faster recovery with an anterior approach or a posterior approach? So we'll talk a little bit about that. So we'll hit all these topics and see what the limitations are of returning to the activities. So what sports are okay? We're going to review this exact same slide at the end. And returning to each of these sports is inherent on the limitation that's involved with each of the sports. So with swimming, it's the incision. With golf, it's the stability of the implant. We don't want a lot of torquing on that hip. Some of it's muscle recovery, some of it's joint capsule recovery. So we'll kind of talk about, these are most of the things that I get taught. I did my fellowship in San Diego. So there were a ton of surfers that wanted to return to surfing. Skiing, snowboarding, running, jogging. I should have put bicycling on that because I get a lot of questions about returning to bicycling, both stationary bike and outdoor biking. A few crazy people like me that like mountain biking. So hiking, walking, golf are probably the most common things that people want to return to. And then we'll talk about tennis and pickleball. Pickleball is just all the rage now. I personally love pickleball. I think there's a really good social component to pickleball that gets people out, gets people social, gets them moving. But there is an injury risk, so we'll talk about that. Contact sports, basketball, football, soccer, baseball, those are less desirable to return to at all after joint replacement. We'll kind of talk about that. Fitness sports, elliptical, stair climbers, weightlifting, yoga, all those are fine, but we need to make sure the implants are nice and stable before we do them. And then we have a lot of dancers. So we'll kind of go through these and talk about what are the limitations. So the incision healing obviously is very important. We don't want to really get the knee too stressed within the first 2 or 3 weeks. Knee incision healing is more complex than hip incision healing. Generally speaking, hip incisions heal with very little, there's not as much skin stretching, there's not as much range of motion, so we tend to have less problems with hip skin healing as compared to knee. But we use a nice kind of a silk dressing that helps the skin heal well in a very safe, kind of protected environment. And the rate limiting factor for like submerging the knee is definitely the incision. It takes about 2 to 3 weeks for the incision to kind of start to heal and seal up. But it takes about 4 to 6 weeks for the skin to be completely sealed and able to submerge. So I usually tell patients at the 2 to 3 week visit that they can't swim for another like 2 to 3 weeks after that. So it's somewhere between 4 to 6 weeks, depending how quickly the skin heals. It's not surprising at about 6 to 7 weeks after surgery, the stitch that we use underneath the skin to get it to heal with no tension, those resorb at about 6 or 7 weeks. And most patients resorb them just fine where there's not much response. But sometimes there's a foreign body reaction and your skin actually spits that incision out. It looks like a little splinter. It looks like it's red, it's hot, but it's very localized to just that little incision. So it almost looks like an infection, but that's called a sterile stitch abscess. And that's not an infection, but we just watch that closely around 6 to 7 weeks. If that's present, we'd probably not want you to swim or hot tub. The skin stays very, very adherent to the joint, especially the knee. It's almost like the skin is stuck down to the joint capsule. And then as you move the knee and as you just live your life, that skin builds a barrier again between the joint capsule and it becomes more mobile. So that can help with pain and range of motion. And then one limitation of knee replacement in particular is the lateral numbness. So lateral means the outside part of the knee. We have to cut through a skin nerve on purpose during the incision. And so that causes numbness on the outside part of the knee that is permanent, but it's also expected. It doesn't tend to cause any problems as long as people are aware of it. So incision healing is a rate limiting factor for swimming. Otherwise, people can get back to swimming really very shortly after the joint replacement. Very low impact, a great exercise. So let's talk about the joint capsule healing. After we get through the skin, then we have to get through the joint capsule. Does it have a pointer? It does. You can probably not see the pointer, right? Can you see that little dot? So we make an incision for the skin directly over the knee, and then the arthrotomy, joint going into the joint, actually cuts through the quad tendon. And obviously the quad tendon is very important. It's what connects the quad muscle to the patella and allows you to extend your knee. If we're too aggressive with quad strengthening after surgery, it can cause that arthrotomy not to heal very well. We want that to heal really well so the patella tracks right in the middle of the femur bone. We use 2 types of suture. One is a permanent suture that stays there forever. The other one is an absorbable stitch, and it takes about 3 months for that stitch to completely go away. The capsule heals somewhere between 6 weeks and 3 months. So quad strengthening exercises, a lot of heavy lifting, bicycling against resistance. We need to be really careful with that until the quad heals. So soft tissue recovery. So we got the skin, we've got the joint capsule, and then we have all the soft tissues in the knee. By soft tissues, we mean the muscles, the tendons, the ligaments. So in particular, a knee replacement, we actually get rid of the ACL. So knee replacements aren't dependent on the ACL, so we cut that out. Most of the time, we keep the ligament in the back of the knee called the PCL, and then there's 2 ligaments on the side of the knee, the MCL, and then the lateral structures that really keep the knee nice and stable. Those don't get cut during surgery, but they kind of get stretched with the retractors and they get moved around, and so those need to recover during the surgical process as well. With regard to the hip, We protect the gluteus maximus and minimus muscles, or the medius muscles, which are the muscles that help kind of power your hip. Those are very important to protect during surgery, but we do release a little muscle in the back of the hip called the piriformis, and we want that to kind of heal up before we do a lot of stretching. So again, these getting the joint capsule and the ligaments to heal before we really try to stretch and strengthen them is important for, like yoga, any squatting, weightlifting type moves, for sure surfing. That's really going to like get your hips and knees in a position where you can't really control them. So we want everything really healed up. This is the most interesting part for me, and I think the biggest limiting factor. And this is where we're talking about the press fit nature of hip and knee replacements. So, this is a hip replacement. I don't know how many of you are here for hips or for knees, or if it even matters, if you're just curious. But so this is the hip joint. So in surgery, we basically make a cut directly through the femoral neck, and we just get rid of the femoral head and the neck. And so we need to replace all that bone that we got rid of. And that's all this. So we anchor a stem down into the femur, and that has a neck attached to it. And we put a new ceramic head on there. So that's replacing all the bone that we took away because it was worn out from arthritis. And then the hip socket, we just basically remove the cartilage away, but we keep all the bone. And then we put a dome hip socket in there, and we line that with plastic. So all the metal pieces are made of titanium, and they look almost identical to this. And there's a porous coating of titanium. Porous coating means there are tiny little microscopic holes in it. So it almost looks like pumice stone, like just little holes. And fascinating that the architecture of the porous titanium matches the architecture of bone, and your body actually just grows bone directly onto that metal. So this basically revolutionized joint replacements. You guys can pass it around if you want, or take a look at it. We've been doing that with hips for a long, long time. And it's proven to be very stable. And now we're doing that with the knees as well. So for a knee replacement, we basically trim the worn out cartilage off the end of the femur bone and the top of the tibia bone. So we make just very small cuts at the end of the bone, which basically amount to that much bone resection. So it's not that much. And that slides on the end of the femur bone. And then we slide the tibia forward. We trim the bone or the cartilage off the top of the tibia, and we impact this titanium base plate on there, and we impact a plastic spacer on top of that. So the new joint becomes the metal femur rubbing on the plastic tibia. So those parts have the same coating as the hip and the cup for the hip replacement. So the backside of this metal is coated with porous titanium coating, and the backside of this is titanium coating. And so the bone grows directly in that. Okay? We'll pass that around too. Here you go. So why is this important for return to sports or activity? So this, in my opinion, is the biggest rate limiting step. Now that we, we're very careful to be kind of minimally invasive surgery. We're very gentle how we handle the soft tissues. We don't want to cause much trauma. Patients can now recover very, very quickly from joint replacements with spinal anesthetic, regional anesthesia, like that's nerve blocks, a really good multimodal pain regimen approach. So the pain is certainly present for a week or two, but patients quickly want to get back to, doing what they want to do. But the implant stability is what kind of limits things, in my opinion. So for the first 2 to 3 weeks, it's really just the friction of impacting those implants into where they go. And it's the bone's job just to support them. So, and then ultimately, there's a healing process that mimics fracture healing. So when you break a bone, your body sends what's called a callus to it. It basically healing potential to regrow the bone. For the first 2 to 3 weeks, that's kind of really soft, jelly-like callus. At 6 weeks, that turns into actual calcified bone, but it's very disorganized. It's not organized bone. It's not structurally sound bone, but it's pretty strong. By 3 months, if we look at it under a microscope, it's actually like structural, normal bone. So that's kind of the process. 2 to 3 weeks, it's kind of sticky. 6 weeks, it's bone, but it's disorganized. At 3 months, it's actual bone healed to the implants and healing a fracture. So that same process takes place with the bone, with the ingrowth. So it's just absolutely fascinating technology that's really revolutionized joint replacements. We as surgeons do take, so the benefit of that is that when we use cement, the cement kind of interdigitates into the bone, goes into all those little crevices, and that sticks to the back of the implants. So day one, cement fixation is as strong as it's ever going to be. And then theoretically, over time, that can potentially weaken and be a weak link for this hip and the knee. And so conversely, when we do the joint replacement, when we impact the joint, that's kind of the least stable it's ever going to be because it's just friction that's holding it there. Ultimately, your bone starts to heal to it, and then it becomes more and more and more of a firm attachment to the bone. So, if we're going to look at a curve, cement fixation is very, very strong and then may diminish over time. Press fit fixation is initially kind of weak, but will strengthen over time. So we're hopeful that because you have bone connecting to the implants, we can be more active longer without the risk of the implants coming loose. Okay, so that's why we use press fit components. Now, the downside to that is that early on, there is some risk that the bone is not strong enough to support the implants. So we as the surgeons take a little bit of a risk doing press fit to trade off for better long-term results. So if your bone is really, really soft, we may make the decision that, cement fixation is actually better here. It's going to last just as long in this patient as it would someone with really strong bone. So we do occasionally still use cement. We commonly use cement. But for younger, active, more active patients with really good bone, we'll tend to use press fit. But it is somewhat of the rate limiting factor. So as orthopedic surgeons, especially as joint replacement surgeons, we pretty much steal everything from dentists. So the bone cement we use, the PMMA, that's from the dentists. All this titanium porous coating technology, that's from dentists with tooth implants. So we pretty much steal everything from them and we magnify it on a bigger scale. So we're kind of just macro dentists. But if we look here, the stability of the implants, this is kind of the key slide. This is the stability of the implant. So mechanical stability means that's just the friction of the fit and the support of the bone. And then the biological stability is when the bone actually starts to grow into it. So there's a curve kind of here to where that's probably about 2-3 weeks. And interestingly, that's kind of the weakest point. And so it's kind of where the mechanical stability is falling off, the biological stability is improving, but neither of them, this isn't at its peak yet. So at 2 to 3 weeks is kind of when people are starting to feel good and they're wanting to get active and they're wanting to really, really go, especially with hip replacements. And that's probably the time where we just want to kind of take it easy. Don't stress it too much and let it be. I would say somewhere around here is probably around like 6 weeks, and around here is probably about 3 months. And then it just keeps going where the biological stability kind of is more like a normal bone. Okay, so this slide I think is the biggest, has the biggest impact on how soon we let patients return. It's kind of a good segue into the approach. So anterior approach versus posterior approach. When I was in training, the anterior approach was all the rage. It's a great operation. We were using imaging in surgery, like a fluoroscopy it's called. So we'd get x-rays in surgery to determine where the implants were going. So doing an anterior approach really was easier because you could get the implants in a really good position with x-ray feedback. Now we use the robotic assistance, and so we can get that same feedback regardless of the approach, anterior approach, posterior approach. So I think the difference is kind of leveled off a little bit as far as the speed of the recovery. But early on, the literature showed that, especially for the first 2 to 3 weeks, patients with an anterior approach healed more quickly with less pain. By 6 weeks, there was no difference. So what I was seeing is that some patients were recovering very, very quickly, and at 2 to 3 weeks, they wanted to let go. And that's actually kind of like the danger zone for the fixation. And someone would get like fractures of the hip, by the stem and that kind of thing. And so my philosophy is that the approach really doesn't matter. because I'm not going to let you hard charge until about 6 weeks anyway, because that's when I feel safe to let you go based on the fixation of the implants. So in my practice, I don't think it's necessarily a deal breaker to have anterior versus posterior approach. In my opinion, they're not going to really affect your rate at which you return to activities. I think there's fairly minimal difference in the recovery. So we talked about the timeline, the rate limiting factors. Yeah, so this whole process is the rate limiting factor for how aggressive you can be and how much high impact you can have. Walking is totally fine. Hiking isn't super high impact unless you're being really aggressive, but stationary bike especially, hardly any impact. So a lot of this stuff you can return to. Golfing is unique because there's a lot of rotational and torsional forces, and the more that you kind of have micro motion of that stem and the femur, it could potentially lead to less strong ingrowth or even fracture. So running, tennis, hiking, stuff that's high impact, you're pounding the joints. In my opinion, that we should hold off on that for about at least 3 months after surgery. And that you may feel physically ready to return to it sooner than that, but the implants themselves and the durability, the fixation isn't quite there yet. So we talked about this, we passed them around, but this is the press fit portion. So all this porous coating, this really roughened metal is where the bone grows to. On the back side of the femur here, on the kneecap, and on the bottom of the tibia. So the wear characteristics and what's related here. So the plastic we use has gotten tremendously improved over the past decade, or even more, probably 20 years. The plastic used to be the rate limiting factor. It was brittle, it would wear out. It sheds little tiny particles as it wears out. Those little particles, they stimulate a really robust metabolic reaction to where your body actually tries to get rid of those particles, but in doing so, it takes some of the bone away. And so that would result in implant loosening. Thankfully, we now process the plastic. It's still the same polyethylene, but we process it differently through radiation and through heat to where now the little, I don't know if they're molecules, but the plastic itself gets linked differently. It's called highly cross-linked, and that has really decreased how much these wear out over time. So we're in a really good era of joint replacements to where now the fixation is biological, to where it's actually bone growing into the metal, so we don't have to worry about the cement interface, loosening. And then the plastic is so durable that it's wearing very, very little over time. So the two rate limiting steps, the weak links, you may say, have greatly improved. And that's important for weight-bearing activities. When I was training 12, 13 years ago, it's almost unheard of to let someone return to running after joint replacements. I'm getting to the point now where I'm almost ready to let people return back to running. Like the implants are that good, the durability is that good, the wear characteristics are that good. So what sports are okay? So at 2 weeks, we want you to walk. Short, frequent walks early on in the recovery are good. Your joints don't like to stay in the same position. So what happens is people are in pain after surgery. They try not to move their joint. Their joint gets very stiff, and then they want to move it even less. So short, frequent walks. If you're going to walk 20 minutes in a day, let's say, for the first few days after surgery, I'd prefer that to be 10 2-minute walks as opposed to 1 20-minute walk, right? Just short, frequent walks, stay active, stay moving, change positions. Don't stay in the same place for too long unless you're sleeping at night. 2 weeks of stationary bicycle is great, but mostly just walking, stationary bicycle, and not much impact. It's okay to shower with the dressing on. And then when we take the dressing off at 2 to 3 weeks, it's fine to shower, just no submerging the knee yet. So 6 weeks, this is kind of right where the implants are starting to get sticky. There's at least some biological activity. The risk of fracture or implant loosening has gone way down. The incision has healed. So now we can really get more aggressive, but it's still not real bone attaching those implants quite yet. So the way I frame or think about return to activity is all those things combined. The joint capsule healing, the muscle, tendon, ligament healing, the skin healing. the fixation of the implant. So I try to be at least somewhat, rational about it or objective about it, as opposed to just like a willy-nilly approach. So swimming is great at 6 weeks. It's fairly low impact. It's not going to stress the joints at all. Skiing, snowboarding, running, jogging, still too much impact. Tennis, pickleball, still too much impact. Golf, there's a lot of torsional stresses with golf. So at 6 weeks, I think no one ever takes time to work on their short game, right? Working on your short game is no fun at all. You want to just crank it and drive it as far as you can. But this is a great time to work on putting, chipping, just not much rotation. And then elliptical, stairs, all that stuff is fine. Dancing's fine, about 6 weeks. So here's where we really, really start to get after it. The implants at 3 months are very, very well fixed. The bone is solidly healed to the metal. We actually see x-ray changes at about 2 to 3 months that confirm that the bone is healed to the metal. And at this point, you can pretty much wind up and go. 3 months, there's almost no limitations. Swimming is fine. Surfing, skiing, snowboarding, I put like yellow, like proceed with caution. You're not going to be wanting to ski moguls. You're not going to want to do jumps. You're going to be very, very controlled. Walking, hiking, I should have put in green. It's fine to hike at this point. Doubles tennis is fine. I wouldn't recommend returning a singles tennis. Pickleball is certainly fine by 3 months. Contact sports, we'll talk about them. They're kind of a special deal. Golf, it's time to wind up and hit a full swing at about 2 to 3 months. You can go unrestricted. You should be good. You will definitely feel soreness, and that's normal. And then all fitness activity pretty much is fine by 3 months. You can start gently returning back to weightlifting. The soft tissues, the bone, everything is healed to the point where it should be safe. And then yoga, we just want to be careful with the hip positions with yoga. There is a position of dislocation with the hip replacement where if you really, really flex your hip up high and let it kind of turn across your body, that could potentially dislocate the hip. So just anytime you have your knee out after hip replacement, that's generally a very stable position. So if you're in doubt, knee out, okay? Okay, so now we're a year out from surgery. Shockingly, it takes about a year to recover from a joint replacement. People at 3 months don't believe me that it takes a year because they're feeling pretty good. But then when a year rolls around, it's almost like they've forgotten about the joint as long as everything's gone okay. The skin now has gotten, more mobile, so it acts like normal skin. The joint swelling has essentially gone away. For the first year, it's expected that the joint stays warm to touch. A lot of people think that there may be an infection or something's not right, but your body is just sending blood flow to that area to get it to heal. So the warmth is normal, swelling is normal, aches and pains with weather changes and a lot of activity, that's all normal for the first year. But now's the time where people really crank it up. You can pretty much return to whatever you want. So swimming, surfing, skiing, running, jogging, we'll talk about those there. Proceed with caution. Pickleball for sure. I have a lot of people that play softball league. So let's talk about those for 1 second. So what can we not do? So like I said, I put running and jogging kind of under the proceed with caution. We just don't know yet the long-term result of people that run. We haven't been using these type of implants for long enough to get 20-year data on if the joints are going to last 20 years. And so I would say if you're doing an interval exercise where you're just doing a little bit of jogging here and there, maybe running like the turkey trot 5K, that's probably okay. Do you want to train with a marathon after joint replacement? I don't know. And we don't really have the literature to say that. The literature that we do have suggests that the small amount of patients that have been studied don't really have a higher revision rate than people that don't run. So my vote on contact sports is just not to play them. If you get hit in the knee and if you get a ligament injury with a knee replacement, it needs a revision knee replacement. We don't really exactly know why the biology is different, but the biology is different such that if you get a ligament injury with a knee replacement, we have to revise the knee replacement as opposed to fix the ligament. In a normal knee, we fix the ligaments. You see football players all the time. They get their ligaments, ruptured. They just undergo surgery to repair the ligaments. We can't do that with a knee replacement. So my vote is avoid contact sports. Not because the implants can't take it, but because if you do have an injury, it's very difficult to resolve. Softball is okay, but no sliding. So as you can see, there are very few limitations to returning to activities. At 6 weeks, people start to golf a little bit, pitching, chipping, certainly biking. You can return to outdoor biking anywhere between 6 weeks to 3 months. Obviously, a fall on a bicycle is going to be bad, whether you have a hip or knee replacement. Like, it's just bad in general to fall on your bike, but having a hip or knee replacement isn't really going to complicate that too much. So any questions so far? Like, what sports and activities are you guys looking forward to returning to after hip and knee replacement? Dancing? Yeah, so dancing is a great one because to your point, there are different types of dancing, some of which are more impact than others, some of which are more turning and twisting than others. And so for the first 6 weeks, we don't really want a lot of impact, turning or twisting. So any dances that do that, I would maybe hold off until at least 6 weeks. By 3 months, no limitations. You can return to whatever you want. Yeah. And golfing, so we kind of covered that in a lot of detail. 6 weeks, it's it's pretty sticky. It should be good. By 3 months, it can tolerate anything. Tennis, yeah. So generally speaking, the recommendation is it's difficult to return to singles tennis. There's a lot of quick movements in singles tennis. So a lot like pickleball, we see some tendon injuries with pickleball, like Achilles tendon ruptures when you try to move really quick, or some like twisting ligament injuries. So those things can happen with pickleball. They happen more commonly with tennis, where you're really trying to cover a lot of distance, change directions really quickly. So singles tennis, we generally recommend not to return to, but doubles tennis and pickleball are fine.
Especially like where you're not really fast moving.
Yeah. Do you play singles tennis or doubles? Doubles, yeah. So doubles tennis is ideal. Doubles tennis is perfect to return to. Yeah.
3 months or so.
I think you can start to like hit some balls at 3 months, so, just kind of swinging, but where you're really trying to cover the court, make some high impact, I'd say 2 to 3 months is kind of the sweet spot. Yeah. Most people feel pretty good around 3 months to return. Yeah. So what are the stats? Like, what does the literature say about returning to golf? Well, most people return to golf at about 4 months. They may try sooner, but they kind of return to golf around 4 months on average. Unfortunately, it doesn't lower your handicap, which I wish it would, but it doesn't. But it does increase the frequency of play. So if you compare patients that were avid golfers before, then they had knee arthritis or hip arthritis and decreased their golf, when they get the hip or knee replacement done, they return to when they were more avid. So they play more frequently than before they had the hip or knee replacement. So frequency goes up, but skill level doesn't. So tennis and pickleball. So despite it's okay to return at 3 months, most patients end up returning at about 6 months to the same level as prior to surgery, similar to the whole golf concept, but with less pain and symptoms while they're playing. So they can play longer and more frequently. The limiting factors in tennis are a little more, the implant stability because of the impact, the pounding. It takes a long time for the muscles to kind of strengthen and limber up again. And so if you're doing a sport that requires a lot of, quick muscle activity, it does take a while to get that reaction back. And then obviously like that range of motion, the responsiveness, it takes a while to get all that back. So the running, like we talked about, the recommendations really, really vary greatly. When patients ask me if they can run, I joke, you can run if a bear's chasing you, but I wouldn't run for exercise. And so, you can run, your knee's not going to explode if you run, and the hip's not going to just blow up. it's fine. But I think there are better ways to stay fit than with running.
Can you go back? Dennis,
Sure.
what kind of stretching?
Yeah, so like a dynamic warm up. So kind of like, some gentle sort of, at least walking, stretching where you're, maybe like knee raises like this, where you're kind of you don't necessarily have to do like high knees, but just really like where you're doing stretching like that. Once you get the body warm, you can sort of, do like these kind of stretches, do some hamstring stretches, just kind of like, most importantly, you just don't want to come off the couch and start playing tennis. Like you want to do 10, 15 minutes where you're just like at least moving around, getting the blood flow going, getting stuff to wake up. Like these, toe raises are really, really good because your Achilles and stuff are going to be tight after the joint replacements. So not really anything specific, but, quarter stretch, like quarter squats are good to kind of like wake everything up. Just get those muscles activated. You don't have to go really deep, but just breaking your knee, letting your knee bend, that all activates your quad and just gets stuff going. So,
Explain implant ingrowth again. I missed that. Impact and rotation.
Yeah, so the implant ingrowth, that bony ingrowth is what we're talking about, to where the bone grows into the metal.
Limiting it if you go back to soon or what?
He had a sample.
You're
That's the
potentially, but most importantly, like if you return to impact before the bone has grown into the metal, there is a chance that we could disrupt that process. But more importantly, there's a little risk of fracture, or what we call subsidence, where the implants kind of subside into the bone as opposed to the bone supporting them.
The rotation.
Yeah, like a big torque, like a rotational stress could do that. More so for the hip than the knee, but even in the knee, yeah. We kind of want to, like, it does okay with straight compression, but any like shear force or rotational force, or angular forces, if you land on your knee kind of crooked and that's an angular force going through it, or so anything that's not kind of straight impaction or straight compression can lead to potentially some fractures or ingrowth problems. Yeah. Mm-hmm.
Now, the reason you're having knee replacement because of arthritis.
Arthritis.
Now, what if the arthritis in here and not over here?
Yeah, so arthritis is specific to cartilage. Okay, so in your joints, where anywhere in your body where two bones meet together, there's a coating of cartilage. It's called articular cartilage.
You're saying
There's no cartilage there because there's no bones rubbing together. So it's only where bones rub where you have cartilage. And so when that cartilage surface wears out and you start rubbing bone on bone instead of cartilage on cartilage, that is what we call arthritis. Arthritis can just be where the cartilage thins, and that's kind of mild or moderate arthritis, or it can be to the point where the cartilage layer is completely gone and you have bone on the x-ray, and that's when we do the joint replacement, when the cartilage is just gone. It's not even there anymore. But so there's no cartilage where you're pointing. It's only cartilage to where bones meet bones. Those are joints. Yep. Anywhere a bone meets a bone, we call that a joint, and every joint has articular cartilage. Your finger joint looks exactly like your knee joint. It's just bigger. Finger's smaller, knee's bigger. Yeah.
In sports. What if you start out from this one? What would that be the same amount of time? Is any of that corrected in the replacement surgery? And then if not, would that make the return to activity longer?
Yeah, that's a great question. So a lot of patients that we operate on have inherent kind of bow legs or knock knees. We call that varus if it's bow-legged, or valgus if it's knock-kneed. Those are the two most typical patterns of arthritis. Either the knee drifts out to the side or it drifts in. And so in surgery, part of the importance of surgery is to correct that alignment. When it comes to like a valgus knee that goes in, we try to correct that pretty straight. And a really big varus knee, if someone was born with a really lot of varus, we may leave just a subtle amount in there, but the leg is going to look fairly straight. So we really correct it, we bring it back. In doing that, though, often we have to lengthen the leg. And so we basically have to, if your knee is really bowed out like that, bowed out like this, these ligaments over time have stretched out a little bit. And so the only way we can make the knee straight is to loosen these just a little bit. So we go from this now to that. And you can see how that's going to lengthen the leg a little bit. So some people do have a little bit of a leg length. For hip replacements, it's very important. For hip replacements, we can really lengthen the leg if we're not careful. So that's where robotic assistance really comes in handy. We can pretty much match the leg length. And then for knees, it has to be a pretty severe deformity to notice any leg length difference. But to your point, we want to correct that alignment so that the forces are kind of going straight through the knee or the hip. For the hip, our goal is to match the other hip. As long as the other hip anatomy is good, we use that as a template. We try to match it up exactly so you feel nice and balanced. As long as we hit those marks, you can usually return to activities.
Pretty much the same.
Yeah. Yep. And it's kind of counterintuitive, but the worse somebody does before surgery, like the more limited they are, actually the better they do after surgery, because the degree of change is so marked. If you go from being almost completely disabled to having a relatively normal joint, that's a huge delta. That's a big change. Whereas if you're just if you like start to have pain on the 18th and you can't quite finish your round of golf and then you're having a joint replacement, that's a pretty fine line between where we need to try to make you better. You're already doing pretty well, but now we're trying to get you better. If you're doing really poorly before surgery, those patients love us. They do great after surgery. So.
Take a bow-legged person, for instance, both legs are. What would you do? Would you straighten one and have the other one?
Yeah, so if we typically don't, I don't typically do knee replacements at the same time anymore. We used to, but I just do one at a time. So yeah, during that interval, if we do one side, that's going to be a little straighter than the other side. Some people are born with just normal anatomy that's a little bowed, but their cartilage is fine. Like this is how they were born. In that case, with the knee replacement, we actually leave them in just a little bit of bow, not as much as they were born with, but not completely neutral, because that's kind of how their knee likes to be. That's how it was made. That's how it wants to be. So we leave it in just a little bit of bow, but if you and I were looking at it, it would still look straight. But the robot tells us that it's in just a little bit of a bow.
If the knee come up and
not all the way straight. Yeah, so that's a big problem before surgery. A lot of people have very bad arthritis that makes their knee stiff and they can't get it all the way straight. Part of the goal in surgery is to make that knee straight. We can get it straight in the operating room with you sleeping and not feeling anything, but then when you wake up, getting it straight is going to be pretty painful. And so that's a very important part of the PT process, is getting full extension where the knee goes all the way straight. So
replacement of the knee, straighten it out? Or
yeah.
It will.
Yeah, we don't really leave the operating room until we're happy with how it comes out straight. Yeah. We don't want to overcorrect it, because one of the worst things that can happen is for a knee to hyperextend after surgery. So we don't want to overcorrect it, but we want to get it straight. Yeah. Okay. That's what.
Will arthritis cause the knee to lock up? It does.
Yeah. Arthritis and meniscus tears. The meniscus is the other kind of cartilage in the knee, and the labrum is the cartilage in the hip, in addition to the articular cartilage. And the labrum in the hip and the meniscus in the knee almost always get chewed up, and there's lots of tears in them as the arthritis worsens. So meniscus tears and labral tears are expected with arthritis. The time we treat labral tears and meniscus tears is when there's no arthritis. So when the cartilage is pristine in the hip or knee, but the meniscus or labrum are injured, then we have the option to fix the meniscus and labrum. But if there's any arthritis, then then the meniscus and labrum are damaged because of the arthritis. So we just leave those alone. Correcting the labrum or the meniscus in the context of arthritis wouldn't help the patient get that much better. Yeah. Okay, but that your previous question, getting the knee all the way straight, that's what makes knee replacement a little more difficult and a little bit more physical therapy focused, is that the patient has a lot of work to do to get the range of motion back in their knee. Yeah, whereas hip replacements is kind of, if you walk, if you give it some time, it's probably going to heal pretty well. There's not as much range of motion demands on a hip as there are knee. Oh, so kind of to my point of playing contact sports. So the original joint replacement is the best joint replacement. So once we start having to do revisions and things like that, we have to take well-fixed implants out of the knee. That causes bone loss. Bone is king. So the more bone we have to work with, the easier it is to do joint replacement. Once we start losing a lot of bone, it gets really, really hard to restore the foundation for which we can put a joint replacement on. It's kind of like building a house. You can't build a house on a crumbling foundation. You need something to build it on. That's me on the mountain bike. So most of the good luck, return slowly and don't overdo it. Don't be a hard charger. And, we all have the weekend warrior mentality. Well, at least I do. I'm working, but a lot of people here might be retired and every day is a Saturday and you're a everyday warrior, which is great. But don't compare your recovery to others. It's like having kids. You don't compare your kids to each other, even though we do, but you're not supposed to. Don't compare your recovery to anyone else's recovery. Your skin, your collagen, which makes up your ligaments, tendons, your bone healing, it is completely different than your neighbor's. And so don't compare yourself to your neighbor. Expect 2 steps forward, 1 step back. The first time you go play 18, you're going to be sore, and that's fine. You're not going to want to play the next day. So 2 steps forward, 1 step back is how it is for the first 3 months to a year. Again, by 3 months, the implants no longer inhibit anything. The soft tissues are pretty well recovered. We mentioned expect 1 year for the swelling, warmth, and occasional achy pain, and may return to all non-contact sports, possibly including running, at 1 year. All right. That's it. You guys have any, what did that take? All right.
These things typically last there.
That's a great question. I actually should have made a slide about that. So there's no expiration date. We can't say it lasts 20 years, 25 years, 30 years. What the data would suggest is that there's a failure rate every year of about 1%, and that just accumulates over time. So, at 10 years, 90% of patients are doing well. The joint has not had to been revised for any reason. And then that just accumulates over time. So at 20 years, it's about 80%. So I always tell people, if you're getting a joint replacement in your 40s or 50s and you want 50 years out of that, it's a flip of a coin as you age, whether you're going to need to have something done or not. So because of that 1% per year that accumulates over time, the later you have the joint replacement in life, obviously the more likely it's going to last your whole life. So people that are getting joint replacements at a young age, and I don't have an age limit, young or old. If you're active and you're healthy enough and you're debilitated enough by a joint that warrants joint replacement and you've tried everything, I think you're a candidate for surgery regardless of age, but with the inherent discussion that if you're on the really old side, there's issues getting through the surgery. If you're on the really young side, there's issues with it lasting the rest of your life. So we just have that discussion. Age does not include or exclude anybody, but there's a discussion to be had with the more complex age-related issues. Okay, so 1% per year that accumulates over time is the best, answer I could give you. Yeah. I never thought in my wildest dreams I would do elective joint replacements on 90-year-olds before moving here, and now we do it not infrequently. Yeah. I can't say it's, it makes us sweat a little bit. it's you don't want to, like, first rule, do no harm, right? And so we certainly don't want to put a patient in harm's way, but if we think we can get a meaningful outcome and they're safe enough to do it, and they moved here because they love golf, they love swimming, they love pickleball, and their joint's the only thing keeping from doing that, it's justified doing that. Living with pain is a bad deal. It changes people's mood, it changes your sleep cycles. It's difficult. And if there's something we can fix with the joint replacement and you're a good candidate for it, that's what I do. That's what I signed up for. You know, I want to help you. Yeah.
All right, let's take a couple questions from Zoom real quick, and then we'll jump back into the room. When can I sit? I love this one. When can I sit cross-legged in yoga after hip replacement?
That's a good question. So that position, your knee is out. And so that surprisingly is a fairly stable position after a hip replacement. You know, take it slow because your hip's going to be pretty stiff. But that position is inherently somewhat stable after joint replacement. So you will feel it being very stiff, you know, that figure 4 position where you feel it's stiff, but over time it loosens up and it's generally pretty safe.
All right, next question. Please clarify, is the meniscus removed during total knee replacement?
Yes, it is. Sorry, I didn't say that. Yeah, so both the meniscus, the medial and lateral meniscus are removed and the ACL is removed. And then the other ligaments we preserve.
Great. Let's jump back into the room. Did we have a question in the back of the room here?
To determine whether someone's a candidate for knee replacement, do you need x-rays and an MRI, or can you tell everything you need to know through it?
Yeah, so that's a really, really good question. So 99% of the time, the decision is made on x-rays. So in x-rays, we look for what's called joint space narrowing. And so when you get an x-ray, it looks like bones are kind of hovering. It's because it's filled with cartilage in the meniscus. And as the cartilage and the meniscus wear out over time, they basically just get, you know, the cartilage erodes and the meniscus kind of gets spit out, and you see bone on the x-ray. And when you see those bone on bone changes, we don't need the MRI to confirm it. When we would get an MRI is when the x-ray looks pretty normal. Then it's not because of the cartilage wearing out, it's something else going on in the knee. If an MRI in that context shows a meniscus tear, but the x-ray of the joint looks perfect, then that's when we do like meniscal surgery, like an arthroscopic debridement, something like that. The meniscus has very low healing potential, so it doesn't necessarily heal. So we rarely repair it unless it's like you're pretty young, 20, 30, 40. Typically, we just trim away the torn portion, and that alleviates the symptoms. So, but yeah, we don't need an MRI. We do get a CT scan on everybody, but it's not diagnostic in any way. It's to allow us to use the robotic assistance. The robot gives us a 3D model of your bone, and then we design the implant, you know, the way we put in the implant, the alignment, the rotation, based on your anatomy that we learned from the CT scan. So we use off-the-shelf implants that are really, really well designed. I think the Stryker knee replacement is really well designed to where it has a perfect circle right here. And then we adjust that based on your anatomy, where we have those circles and try to match your anatomy perfectly and balance the ligaments really well. So it's standard off-the-shelf implants, but the alignment is custom to your anatomy. Typically, we like it to be about, you know, within 6 weeks of surgery. Sometimes it'll just be a week or two before. Occasionally, we have people that really, for whatever reason, they get postponed because of a cardiac issue or a medical issue or something. And so in that case, the CT scan is kind of good for about 3 to 4 months. If it's been more than 3 to 4 months, or especially 6 months, then we'll get a new CT scan. So it's more accurate at the time of surgery. But
I got a question, it's not sports related, but dental work after surgery.
yeah, that's a great question. So yes, and this is also really variable. Our group has kind of decided to kind of all be on the same page. And so within the first 3 months of surgery, so at the surgery for 3 months after, we recommend no dental work unless it's to take care of an infection. Then we want you in as soon as possible to get taken care of. But routine sort of maintenance dental work, we recommend a 3-month break after the joint replacement. And then for the first year, we want you to take antibiotics. So prophylactic, preventative antibiotics about an hour before dental procedures. And if you don't have allergies, we typically just use amoxicillin, which is very well tolerated. And then after the first year, the risk of having an infection really goes down. We had talked about before that your body is sending a ton of blood to the knee or hip, and that's why it's warm, it's swollen, it's a little achy. It's because your body's trying to heal it. It's sending more blood flow there. So theoretically, if you get an episode of what we call bacteremia, where there's like bacteria in your blood, that can happen during dental work that could theoretically land in the hip or knee replacement and cause an infection. It's a very low risk, but it in theory does happen. And so we try to protect against that. So no dental work within the first 3 months, antibiotics for the first year, and then you should be good after that. You can have dental work in preparation for surgery up to about 2 weeks before. So we want you to get all the dental work done. We really don't want people to have surgery if they have a lot of infection in their teeth, because that can lead to infections down the road. Really any infections at all. So after you get a joint replacement, you need to be very vigilant about making sure skins don't get, skin tears and stuff don't get infected, no dental infections, no GI infections, stuff like that. And if you do get them, you got to get attention immediately, because it can theoretically cause an infection in the joint replacement. So, okay.
Another question? If not, can you talk a little bit about within Desert Orthopedic, the system, how do you work within pain management as well as PT, either pre or post surgical?
Yeah, that's a really good question. So, patients ask about prehab a lot. Like, is there a benefit to doing therapy before surgery? It's a little bit hit or miss. You just want to kind of stay active and get as much quad strength as you can. But after therapy, it's very important. So I'd say it's a little less important with hips than it is for knees, but it's still important for both. We have a home health nurse and physical therapist come to the house. They typically work at your home with you for the first 2 to 3 weeks when you're a little bit more immobile. And they come for 2 to 3 visits for 2 to 3 weeks. It's usually about 6 visits. And then at that point, if you still need it, we transition to outpatient physical therapy, where you come to one of our clinics. We have 2 in La Quinta, we have 1 in Palm Springs, 1 here in Rancho Mirage. And then there's lots of physical therapy clinics outside of our system that we send people to as well. But they'll focus mostly on range of motion, stretching, strengthening. For the knee, it's very important to work on range of motion. For the hip, it kind of just gets better with time.
All right, thank you. And then in pain management scenario of that, do you work within the team as well?
Yeah, so we have a really robust pain management service. They do a great job, especially for hip replacements. There's often a crossover with spine problems. And so, hip arthritis pain typically hurts in the groin. If you're having pain on the side of the hip, or especially in the back of the hip, that may be related to the hip, but it's more commonly related to the back. And so having physical therapy and pain management help get the back more stable, supported, treat any degenerative changes with like an epidural or a nerve root block, or there's other injections we can do. But the pain management service is vital for all of us. They're very good.
Fantastic. Questions here in the room? Additional? Go ahead.
Yeah, that's a good question. I would probably not do a power plate with a lot of vibration until 3 months after surgery for that ingrowth reason. But after that, I think it's just fine. Mm-hmm. Yep.
All right. Additional questions from Zoom or in person here in the room? And if not, nothing yet. Dr. Briggs, do you have any last final thoughts?
I don't think so. I think we're good. Thank you guys for coming.
All right.
Appreciate it.
Well, thank you, everyone. And as I mentioned, it is recorded. It will be on the websites and at our YouTube channel within the next couple of weeks. Thank you much for joining us, and have a great and safe evening.